excited to speak with you. We both have been lucky enough to speak with this group on previous occasions, and it has always been so rewarding. You are a wonderful audience and very thoughtful and ask excellent questions. And so we are both really excited to be here. And I am going to drive the slides since I'm going first. Katie, while I'm pulling those up, do you have anything you want to add?
No, I don't think so. I share Jessica's sentiment. We have always enjoyed sharing knowledge and time with the staff from BDMS. So thank you again for your time and your attention.
And Katie, do you want to explain your new role to them? Because
Oh,
it's
sure.
novel to them.
Yes, so I am a geriatrician. And an internist. So that's my clinical hat. I recently moved into a physician administrator type role in the quality management sphere. We call it episodes of care, which is all about moving away from a sort of quintessentially American fee for service payment model and more towards um, uh, payment models and care systems, care delivery that really focuses on the right care for the right patient at the right time in the right place. Which has been a real shift in thought and shift in how care is delivered at OHSU and other care environments in the United States. So, I my new title is Episodes of Care Medical Director for Medicine and Cardiology.
Excellent. Thank you. Before we get started, please, I get very excited and I sometimes speak fast. I will try not to speak fast, but if I get ahead of myself, feel free to wave a hand or come off mute and ask me to slow down. And then I won't be able to see the chat. So if you do have a question and you put it in the chat, we'll address it at the end, or you can come off of mute and ask your question. And then we'll have time at the end for questions and cases as well. So our goal during this session is really to get on the same page of delirium and come up with talk about a good definition. We're also going to discuss the spectrum of symptoms that you will see when a patient has delirium and really start to work and develop a framework for how we manage these symptoms and hopefully help to minimize or resolve delirium. We're going to discuss some important considerations when for prognosis and family counseling for patients who experience delirium, and really work to reframe behavioral symptoms as a means of communication for patients who have delirium, and talk about some strategies when those symptoms come up. And then we're going to unpack and familiarize ourselves with tools we all have across all disciplines to address these intrusive behaviors. So delirium, we want to stress, is a medical emergency, and there's going to be information throughout this presentation and when my colleague Dr. Drago shares that really hits home why it's important to prevent delirium, or when it occurs, really be on top of addressing it. And delirium is, we think of as acute confusion or an acute brain failure. And then another term you've probably heard is encephalopathy. And this really develops as a result of both an intersection of underlying risk factors that our patients have, and then specific situations or stressors that occur that increase this risk for delirium. And an interesting statistic is that about 30% of delirium cases are recognized, which really means that what we see is just the tip of the iceberg, and that 70%, or about 2/3, are never recognized or are misattributed to something else. It's important to be able to identify delirium because these patients spend longer in the ICU, they spend longer in the hospital. They're at an increased risk for things like mechanical ventilation or other procedures. And not only is there an increased risk of cost, but there is a significant risk for mortality for patients who experience delirium. And that's why we stress that it really is a medical emergency. This is a a slide with a lot of information, but really the point is to let you know on the left-hand side are predisposing factors for delirium. Those are the things that our patients come into the picture with that increase their risk for delirium. And then on the right are things that either we do that cause delirium. Oh, for some reason my screen went off. That we do that cause delirium, or that patients experience that can cause delirium. And it's really the underlying characteristic and the things that occur for patients that make this occur. And as mentioned, it's this acute confusion, but there are some central hallmarks.
Jessica, can I interrupt you?
Yeah.
Your slides are no longer showing.
It did switch off. Okay, hold on. Let's try to get it back. Do, 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 do. All right, you guys let me know if it's working again.
Success.
Okay, thank you. And that's exactly what I want everyone else to do if I end up going astray. Thank you, Katie. Let's see. So let's get to where we were. Perfect. So a hallmark of delirium is inattention. It's also characterized by disorganized thinking, and it has to be an acute onset or change. And that means, you know, from a geriatrics perspective, we have to know what someone's cognitive baseline is to be able to know if this is a new change. And confusion can't be delirium if it doesn't demonstrate inattention. And we'll talk a little bit more about that in detail. So what is inattention? It's really the reduced ability to maintain focus on external activities or to shift focus between activities. And examples of this are like not being able to multitask or an inability to sustain a multilateral conversation. And we've all seen this in patients where you're trying to speak with them and they're kind of attending to things outside of the room or outside of the sphere, and they're just not able to maintain that concentration for the conversation. And disorganized thinking is when the thought content is disorganized, or if someone demonstrates a deficit in logic. And an example to this is answering a different question than what was asked, or an inability to answer simple questions, which you know they would be able to do if they weren't acutely confused. Other things that are important to note that often come along with delirium are disorientation. People will have memory and language impairments. They can have misperceptions of stimuli, and hyper or hypomotor activity. One of the reasons why delirium is often not recognized is a lot of patients experience a hypomotor activity. And those are the ones that we don't hear about very often because they're a little more somnolent, they're more tired than usual. It's often the hypermotor activity that gets everybody's attention because these people are restless or picking or pulling at lines. A common associated symptom is an altered sleep-wake cycle, and for some people, a complete reversal of the sleep-wake cycle. And then it's not uncommon to have emotional lability, anxiety, depression, and even suicidality along with it. And up to 40% of people may voice some life-ending desires. And we actually see that a lot in the hospital. So when patients are saying like, just let me die, just let me go, you really should have a threshold for thinking, I wonder if this is a statement because they are delirious and not necessarily a statement that they would make if they weren't in this acute confused state. Now, we don't 100% know what is happening in the brain when someone has delirium, but there are some patterns that have been identified in neuropathology. Acetylcholine plays a part in attention, memory, perceptual disturbances, and organization. And it's hypothesized that a deficiency in acetylcholine causes delirium. But a normal part of aging is a decrease in acetylcholine. And so that is one of the reasons why older adults are at higher risk for delirium. Also, serotonin, which plays a part in wakefulness and mood. There's a suggestion that low tryptophan levels lead to low serotonin, again, precipitating delirium. Dopamine, which plays a part in hallucinations, perceptual disturbances, and motor activity, there can be an increase in dopamine through downregulation of metabolic enzymes. And this is often the kind of cause of this hyperactive form of delirium that we were talking about. And then GABA, there seems to be a relationship with the low levels in specific cases, especially common in sedative withdrawal. And all that to say, Katie's going to talk a little bit about a forest fire that happens in the brain. And I think, you know, with all of these levels that delirium is effective, or that delirium manifests with neurotransmitters, I think you can get the sense that it is definitely a forest fire. Something to remember is that not all confusion is delirium. People can have dementia and be confused. They can have traumatic brain injuries or developmental delay, even anxiety or depression, bipolar disorder, or primary psychotic disorders. That doesn't necessarily mean that they have delirium. And that sleep deprivation, undertreated pain, and medication side effects can also potentiate this. And it's important to really tease out what is happening, because our treatments and our prognosis are really different for each one of these different scenarios. So let's get into assessment and diagnosis. So we have kind of this risk assessment, screening, and diagnosis kind of spectrum for when we think about delirium. And risk assessment, usually in the hospital for us, this is done by nurses or occupational therapists. And it's really getting back to that previous slide of what are the underlying risk factors that patients have that could increase their risk for delirium. Then when it comes to screening, we do this, nursing staff does this, but also providers can do this as well. And
ผล MRI อ่ะไม่ได้กดทับเส้นประสาทหรือไขสันหลังนะคะ
I think someone is unmuted.
มันมีความเสื่อมอยู่แล้วก็มันมี
Everybody mute,
มันเหมือน
please.
มีการอักเสบอ่ะซึ่งอาจจะเป็นจาก
I think I did it.
Thank you, Connie. So for screening, we use the CAM or the CAM ICU, and I'm going to go into further details about that. But there are other screening methods that you can use as well. And then diagnosing really needs to be confirmed by one of the providers. It's helpful to have all the information ahead of time to screen, but the diagnosis is really important, especially because if it is delirium, we're going to handle it differently than other things. And we're going to talk about how you go about doing that. So on the left of the screen, you'll see inattention. And these are the tests that we use to determine if someone is having inattention. Serial sevens can be a helpful one. Someone spelling world in reverse. Casablanca is where you spell that word and you have someone squeeze your hand when they come across the letter A. What we often use on our service is days of the week backwards or months of the year in reverse. And then another helpful thing is social attentiveness. And a lot of the geriatrics assessments are really done in a very social way. When you walk into that room, is someone able to track you with their eyes? Are they attending to something else? Are they focused really on picking and pulling at their gown? Just by observing someone and engaging in a regular conversation, you're able to get a lot of this information. Same with disorganized thinking. You can ask, does a stone float on water? Is 2 pounds heavier than 1 pound? But also if someone is having this rambling, irrelevant conversation or unable to stay on topic as you're talking, those are markers of disorganized thinking as well. And then this handy table kind of shows you the sensitivity and specificity of each. There isn't one where you're like, great, each one is 94%. That's the only one I'm going to use. And so it's often a combination of these tests that really give you the best sensitivity and specificity. Something to really pay attention to, though, is that often when people are highly educated or well socialized, they can cover up delirium pretty darn well sometimes. And so it can be hard to tease out some of this inattention or disorganization. And so you can start with kind of the least complex assessment tools and then just start moving up the chain. And an example I think of often is I had a patient who had a doctoral degree in mathematics. And serial sevens for him was no big deal, but he couldn't spell world backwards. And if I hadn't done a couple of tests, I maybe wouldn't have picked up on that. So all of these tools are helpful and should all be in your toolbox, with different ones having different relevance for different patients. What if I'm still unsure? Well, you just wait and observe. A very hallmark pattern to delirium also is a waxing and waning. So you may come in and it's the patient's best moment of the day and they look great. And then you get a call an hour later and the nurse is saying they're hallucinating. And you're like, well, I was just in there. And that is because there is this up and down pattern. So if you're not sure, just wait, come back, symptoms will manifest or they will not. And that's why it's also important that we're doing these continual screenings. So it's not just one-time screen and then the decision is made. This really needs to be done on a pretty regular basis, like we do it once a shift or if there's a change in status. So let's move on to treatment. The thing to really ask is, why now? Why was someone humming along okay and now they're not? And that's important to ask because that's going to help you determine what you're going to treat. So examples of this does someone have a developing infection? Is there a new medication that we've started? Or sometimes, are they on a regular medication that we have forgotten to start and now they're withdrawing from that? Have they had terrible sleep all night? So really getting to the root cause of like, why has something changed? Why all of a sudden are they delirious? Really helps us kind of tease out what we're going to do next. And we did a little example. I think there's enough people that we're not going to be able to shout out what everyone thinks their answer is. But we have a 98-year-old retired RN with dementia admitted for 3 compression fractures and 4 rib fractures after a sustained fall. She normally sleeps from 2 a.m. to noon every day, but hasn't slept since admission, which is very common in the hospital when people have a non-hospital sleeping pattern at baseline. She's unable to call for as needed opioids and has spent most of her day in bed and now unable to have a conversation and is misperceiving the bed alarm as a doorbell and is a lot more emotionally labile than she was before. So already from that case and from what you've heard so far, you probably have some red flags that you think might be causing her delirium. And for this individual and for all older adults, I would say the nice thing about addressing delirium, preventing delirium is it's just good care for all older adults. So you're in good stead if you adopt these things, whether your patient's delirious or not. But recognize that not all patients will ask for pain medications. And some people, especially when they have that hypodelirium picture, are unable to advocate for themselves. So addressing pain, that's a big driver for her. A way that we do that is make sure that we schedule some Tylenol, that sometimes we add a short-acting opioid with some low doses of as needed for those patients who are unable to advocate for themselves. And then making sure that we try to adhere to someone's regular sleep routine. That's hard when in the hospital they're doing blood draws at 4 a.m. But is there any way that we can shift the schedule? I think this is especially relevant when we're thinking about ideal times for therapy disciplines to work with patients. And then adding a little bit of melatonin, maybe even some as-needed trazodone, and as a last necessary thing, you can add some low-dose quetiapine. And then immobility is a big driver for delirium. So making sure that people are up in the chair, that we have them out of the bed to use the restroom. We're not using a Foley catheter or anything like that to make sure that we're enforcing that mobility. And then don't forget that any insult to the body or brain can precipitate delirium. And we'll kind of go through different organ systems to reframe our thinking about this. So looking for dehydration or volume overload, those are big drivers of delirium. Do they have electrolyte derangements, especially with sodium or calcium? Again, are there medications that we started, or are there medications that they're withdrawing from that we forgot to restart? Antidepressants are a really common one for patients to have delirium if we don't restart them. And then sleep deprivation and systemic infections. But also be thinking about musculoskeletal injuries. Sometimes, unfortunately, we've ended up in situations where we're consulted for delirium and it ends up that someone had a fracture that wasn't recognized, that didn't get picked up, especially when someone's confused and they're not able to participate in the exam. So always have a low threshold for repeating that kind of pan scan exam to see if someone doesn't have a musculoskeletal injury. And then stroke, cerebral hemorrhage, a myocardial infarction, heart failure, sepsis, and other forms of shock can also precipitate delirium. And then, of course, traumatic brain injuries or an acute concussion. Any organ failure can technically cause it, some more than others, but that should be on your differential. And then commonly we see constipation or urinary retention. And then always, if you have someone who has underlying cirrhosis, think about hepatic encephalopathy. But delirium can also be one of the first precipitating symptoms if someone has a developing internal hemorrhage or some localized infection. And then, as I mentioned before, all delirium care is also good care. So patients who aren't delirious also benefit from this, but really making sure that we're maintaining their sleep-wake cycle, that we have them out of bed at least 3 times daily and walking around the room or halls as tolerated, that we're making sure that we address their pain, and keeping in mind too that when people have spent a long time in bed and they have some underlying arthritis, that can be pretty uncomfortable too. That we're keeping an eye on their oral intake, trying to ensure that they're getting enough fluids. And most older adults that we see, most, not all, fluid restrictions aren't really needed. Most older adults, we're kind of having to encourage them to drink fluid. So really being thoughtful about either the fluid or dietary restrictions that we're recommending to people. And the goal should be a bowel movement per day, and that we're also addressing urinary retention with avoiding Foley placement, because that central line that can either prolong delirium or make it a lot worse. So really doing scheduled toileting, encouraging people to get up. And if there is any retention, trying to use straight cath to kind of get the bladder emptied, but getting it back online rather than a Foley catheter. And then anytime someone is delirious, really taking a good look at those medications. Did we start something that's causing this confusion? Are they on these high-risk medications like anticholinergics? A lot of antiemetics promote delirium, and then benzodiazepines, of course, are high risk for delirium as well. And then if someone is exhibiting behaviors, really thinking about that as the delirious person's attempt to communicate their unmet need, whether that's pain, whether they need to go for a walk, whether they, need to have a bowel movement, if they're thirsty, hungry, and really trying to drill down rather than just treating the behavior, to think about that, how that behavior is manifesting itself. And then encourage visitors, family, and friends to be with the patient throughout the day. This will not only help as this cognitive anchor, having a familiar face, but will keep them engaged and stimulated, and also do that reinforcement of that, sleep-wake cycle. And then prevention is key. Katie and I will tell you that it is much easier to prevent delirium than it is to undo it once it has started. And again, delirium prevention is all of that supportive stuff that we just talked about that is also great for older adults and probably younger adults too. I would want my sleep-wake cycle maintained if I were in the hospital and my pain treated and being mobilized. So all of it is good care, and preventing delirium is much easier. And in fact, there was a meta-analysis, a really large one for almost 3,000 patients, that showed that about a 40% reduction in delirium was found when they used a multi-component prevention regimen. And that is all of the things that we talked about: addressing sleep, mobilizing, making sure pain's treated, adequate nutrition and hydration, and that just by doing those things, that good supportive care, they were able to reduce incidence of delirium by almost half. So now I'm going to turn it over to my colleague, Katie, who's going to talk to us about prognosis and counseling.
Jessica, I figured this might be sort of a nice natural pause. There's been a lot of information, some of it new, maybe some of it old, but not used in a while. Are there questions or thoughts or observations? Okay. Hearing none, we're going to move on. Certainly, if you think of other questions or comments, throw them in the chat or to raise your hand and interrupt. We're happy to stop and clarify. So, delirium is an odd condition, in part because it can look so many different ways, and every person is going to wear acute delirium very differently in their behavior, in their symptoms. But there is a common pattern. There is a common thread to how delirium unfolds and blossoms, and then what we expect from the recovery. The best metaphor that I have ever come across is considering the natural course and natural history of delirium as being akin to a forest fire. Forest fires, we live in the Pacific Northwest and the West Coast of the United States, where forest fires and fire season is a very common thing that we go through every summer and early fall. For those who may be less forest fire savvy, forest fires never start for just one reason. They always start at the confluence of multiple different things. The forest is dry, maybe there's lots of brush, things haven't been cleared out. There's a lightning strike, there's a campfire that sort of burns over. There's this congruence of different risk factors and inciting factors. That is exactly how delirium develops. And with forest fires, the blaze may start small, but they grow very, very, very quickly. And this is the point in delirium where we commonly come in and either recognize it or at least recognize that something is wrong, right? Something is changing. Next slide, Jessica. There we go. The natural history of forest fires is that firefighters will talk about containment. And containment just means that the fire is not getting worse. It's not taking up more space. It's contained. We've wrapped our arms around it. The same thing happens in delirium. Once we accurately and efficiently address all of the driving forces, the modifiable forces that we can, that delirium is considered contained because it's not getting worse at that point. But it doesn't mean the delirium is done, that it's fully resolved and people are healed. Just like a forest fire, weeks to months later, there's still firefighters on the scene trying to put out burning embers, little flashes of fire that pop up here and there. And it actually takes weeks to months for forest fires to actually fully extinguish. And that is exactly how delirium recovers. The sort of active blaze part may only go on for a few days, a week, 2 weeks, but the overall recovery that that person and their family are going to experience is going to be weeks to months of all those little burning embers, all those little moments of confusion, disorientation, trouble with word finding, trouble with complex thinking, are going to slowly settle over that time. Weeks to months after the active blaze, the sort of active initiation of delirium, patients commonly experience issues with complex cognition. So executive functioning, planning, complex activities, abstract thinking, concentrating on tasks that maybe they could do just fine before, other complex calculations or plans, and sort of the highest order cognitive functions. And patients will come in in follow-up and complain about these things, or family members will notice mom, dad, spouse, friend just does not seem the same as they were before they got sick. The same thing happens with mental health conditions. Post-traumatic stress reactions, anxiety, depression are all incredibly common, especially in those who were in the ICU and were critically ill on mechanical ventilation or vasopressors or other sort of ICU levels of care. This is still a very active area of research. The best numbers that we have so far come from a pretty small study, and it was overwhelmingly a third of survivors of delirium experience some residual mental health conditions. Next slide. This too is another active area of research into the spectrum and the relationship between episodic delirium and later cognitive impairment and development of dementia later on. A lot is going to change in this area over the next 5, 10, 20 years. We're just really starting to learn and understand this relationship. But there is a definite increase in risk of developing downstream dementia after a single episode of delirium. The best metaphor and the way I think about this and teach learners is it's exactly the same relationship between acute kidney injury and chronic kidney disease. That you can have one really severe bout of acute kidney injury and kidneys will be left with chronic kidney disease. Or you can have multiple bouts over time of significant acute kidney injury, and that will ultimately lead the patient to developing chronic renal impairment. Exactly the same relationship between delirium and dementia. So on the flip side, if you are assessing patients in recovery or even a couple years after they had a significant episode of delirium, thinking about that as an independent risk factor for developing dementia is pretty important. Next slide. Delirium can be really, really scary. You all are fully cooked providers, rehab specialists, physiatrists. I'm sure you have experienced patient care situations where patients were scared if they knew something was going wrong and didn't feel right, and families were really scared, thinking this is not the person that I know, not the person that I love. In the States, we do hear these concerns really, really commonly. It's really important as a provider team, an interdisciplinary team, to explain what is happening, particularly the fluctuating nature of delirium, that there are going to be parts and times of day and even days of the week as the recovery is unfolding where patients may look better. And then they're going to be followed by periods where they don't look quite as good. That does not mean they're regressing or things are getting worse again. That is just a normal part of the recovery and the natural course of delirium. This is especially important when patients are experiencing behavioral symptoms and maybe disinhibited behavior, aggression, restlessness, impulsive movement, anger, real behaviors and emotions that may not be typical of who they are. It's pretty important to let families know that we know this is not who you love. Their brain is still out at sea right now. Once you're through the sort of active management phase, the counseling should really shift to what we expect in recovery. And I do use that forest fire metaphor with patients and families. It does seem to take what can be a really complex topic and lend at least a framework that a lot of folks are familiar with. Next slide. There's some really great patient-facing and family-facing resources that are out there on the internet that we do recommend to people pretty routinely. This is from Vanderbilt University in Tennessee, from their Critical Illness Survivorship Center. They have a whole section dedicated to resources for patients and families, and a lot about delirium and particularly post-traumatic stress in recovery, anxiety and depression. Next slide. This is a new site put up by the Harvard Aging Brain Center that too is all focused on delirium, not just critical illness and ICU survivorship. This really speaks to delirium in all settings of care. And they too have a specific patients and families section. One caveat that is important to know is that neither of these sites carry translated information in Thai or other Southeast Asian dialects. They're predominantly English, and I think they may have Spanish conversion, but translation. If you want to recommend these to patients and families for whom English is not their fluent language, you will want to ask for translation support. Next slide. So we're going to shift gears and talk about an issue that I know is near and dear to everyone's heart, and it's managing complicated behavioral symptoms. Next slide. So behaviors, we're talking about them. I'm sorry, my dog is going a little nuts right now. Behaviors commonly happen in delirium, and that's the context in which we're discussing them. But this same advice and the same recommendations that we're gonna talk about can also be applied to people with dementia-related behaviors, people with autism spectrum disorders that may have complicated behavioral symptoms, other developmental delay conditions, people with traumatic brain injuries. The same management framework works for everyone. We're just bringing it up in the context of delirium. Behaviors can range from anything from hyperactivity, restlessness, aggression, anger, exit seeking, real kind of high activity behaviors, all the way over to the opposite end of the spectrum, which is hypoactivity, lethargy, withdrawal. I've heard other geriatricians in this country make jokes about these being the nurse's favorite patients because they are so hypoactive. They're not asking for things, raising questions, raising need for care. They are just sort of fully withdrawn. And that too we consider an important behavior to recognize. Behavioral symptoms are going to fluctuate over the course of the day. They are particularly tied to fatigue. So patients that are dealing with active sleep deprivation, that is going to definitely worsen behavioral symptoms and make them more active, paradoxically. Also just the fatigue of the day. So even if people are sleeping at night and they're awake most of the day, just the fatigue of being awake and socially engaging, moving around, talking to people, eating meals, doing very basic daily activity. When someone's recovering from delirium, their ability to deal with fatigue is lessened. And so even the fatigue of daily living may actually exacerbate some behavioral symptoms. Next slide. Jessica prefaced this before, but we believe that behaviors and behavioral symptoms are a method of communication for any patient who is cognitively or communication impaired. This is our natural impulse as human beings, that if we aren't able to verbally relay, here's what I need, here's what I'm feeling, particularly as adults who have lived independently, we're just going to get up and try to meet those needs on our own. So I think about two big buckets of unmet needs. Next slide. The physiologic and the psychologic. And it's pretty basic human needs. So the physiologic needs being I'm hungry, I'm thirsty, I need to pee or poop, my body hurts or my body is stiff, I'm too hot, I'm too cold, I can't see, I can't hear. And then the psychologic really speak to more I'm lonely, I'm bored, I'm anxious, I'm disoriented. I don't know what's happening around me, so I'm going to get up and investigate. Or a desire to restore some sort of familiarity, right? I have a routine. I'm trying to restore it. Next slide. This is another framework for breaking down those more active behaviors. In the States, I'm not sure how this works at BDMS. I certainly hope you all do not have the same problem, but in the States, it is really common for us to just batch all active behaviors under the heading of agitation. And this comes, I think, from the psychiatric world in dealing with people with really severe mental health conditions, and has slowly sort of leached out into care for other cognitively impaired patients, which is not really the same patient population. And so what happens commonly in the States is that frontline caregivers like nurses, CNAs, other providers will reach out for help saying this patient is agitated. And unfortunately, that term really means everything and nothing. It's sort of become a garbage term because it could mean and is used commonly for everything from pain-related behaviors like wincing, grimacing, yelling out, help me, help me, help me, which is a great surrogate for pain until proven otherwise. Um, to restlessness like picky pulley, disrobing, impulsivity like exit seeking, trying to leave, to believing they need to go somewhere or do something, all the way up to aggression, which is everything from hitting and scratching to pinching and biting. And so the term agitation really doesn't capture the different nuances of all those different types of behaviors and what might be driving those particular behaviors, those specific unmet needs. So our recommendation is to not use the word agitation at all. Instead, use these more descriptive terms. They're restless, they seem painful, they're anxious, they're being physically or verbally aggressive. Those actually are more useful terms to both try to figure out what the unmet need is and also try to determine how quickly do I need to act for safety purposes, maybe with other quick interventions. Next slide. There we go. I thought I had this in here. The take-home point is don't use agitation. Use a more descriptive term. Your toolbox for addressing unmet needs is actually very, very full. And there's a lot that we can do to help adapt the environment and also adapt the clinical care to meet some of those unmet needs. This is a nice resource reference slide. So I'm hoping that Connie will be able to help us make these slides available to you all as a reference. This is a really nice reference slide, just as a reminder if you need a checklist for the things that you can do to address some of those common unmet needs. Next slide. So, big question that we get a lot is when do I prescribe something like an antipsychotic? There are lots and lots and lots of opinions about this. And there's differences in practice, in part because there is no set standard. There really is no sort of universally applicable standard of care. There are distinct pros and there are really distinct cons. It is our approach at OHSU that, and for most geriatricians actually, that antipsychotics can be a helpful tool, but it's you need to gear them towards the right patients with the right symptoms in the right circumstances. Next slide. So no medication, none, has FDA, Food and Drug Administration approval for treatment of delirium. And this is the gold standard in the United States. I'm not sure if how FDA approval is taken in other parts of the world, but at least for us, this is our government scientific reviewers saying what is each drug good for, what are the safety concerns, et cetera, et cetera. So this is sort of the gold standard for us, and no medication so far, antipsychotic or otherwise, has achieved FDA approval to treat delirium. So by default, any medication that we use to address behavioral symptoms of delirium are really symptomatic management. It's like treating nausea with an antiemetic, or treating itching with an antihistamine or a topical cream. It's only treating the symptoms of the delirium. It's not actually treating the underlying delirium. There was there's a couple of great meta-analyses that were published in the Annals of Internal Medicine in 2019 that are referenced here that looked at all sorts of randomized controlled trials and cohort studies to look at antipsychotics specifically on delirium prevention and on treatment. And long story short, they found no benefit. There is absolutely no benefit to treating the underlying delirium with antipsychotics. And there was a small but very real increase in neurologic and cardiac side effects with even short-term use. So there is no benefit and it comes at a bit of a cost. Next slide. That said, Katie Drago is about to walk back what she just said, that there will be those patients for whom an antipsychotic actually is appropriate to help keep them safe, keep the caregivers and family safe, and help the patient feel calmer. So here's the threshold that we use routinely when we're thinking about whether or not a delirious person needs an antipsychotic or might benefit, is the better term, might benefit from an antipsychotic. They are completely non-soothed or redirectable by other less invasive means. So we are always talking with frontline caregivers to get a sense of, what have you tried already? Have you tried treating pain? Have you tried offering food? Have you tried some mobility? Have you tried a change of circumstance or change of scenery? What else have we tried? Just to get a feel for what's been done and what is not working. Any aggression, physical aggression that is posing a distinct danger to the patient themselves or the staff, that will warrant medication therapy, because those can turn really consequential very quickly. Any behaviors that are actively interfering with truly critical and necessary care. So say for intubated patients or patients that are on CPAP or BiPAP, where the mask really needs to stay on. But there's just so much restlessness and so much impulsive movement that it's posing a distinct risk to their breathing. That is a really good indication to try an antipsychotic. The one other situation where I do use them just purely for a palliative and symptom management reason is for delirious patients that have really distressing psychosis, so really scary visual hallucinations. We've had patients on our service that were seeing fire all around them, that were seeing snakes and bugs on the wall that were like creeping towards them. I had a patient that I will never forget who described the nurse's station, what he saw at the nurse's station, as being a satanic orgy. That was just very, very scary for him. And so from a human perspective, we use that as a really good reason to use an antipsychotic, just to turn the distress down, because that's a really uncomfortable state of being. Next slide. The goals. What are we trying to achieve here? We are not trying to achieve chemical restraint. That is not the goal. The goal is not sedation or somnolence. The goal is to ideally achieve a wakeful calm, where patients can be awake, they can be engaged in activity and engagement with caregivers, but calmly. We want to turn down the volume and intensity of the behavioral symptoms, and ideally be limited to a short-term use. Nothing that we use for delirium behaviors should turn into a long-term treatment strategy. The duration of short-term can be anywhere from just a couple of days to maybe a few weeks, depending on the severity of the symptoms and the severity of the overall delirious episode. All of that we would still consider short-term use. Next slide. Here's another reference slide. There are 4 commonly used medications that we double checked, and I believe these are the generic names that are available in Thailand and in Southeast Asia as well. If they're not, please call that out. But these are the 4 medications that have been studied, some pretty heavily, some a little less heavily, for delirium specific related behaviors. Again, these medications have no benefit in actually treating the underlying delirium, but they do have a role in treating the symptoms. Starting doses are listed in that second column. You may be looking at this and thinking, Dr. Drago, these are really teeny tiny doses of these medications, and you are exactly right. Particularly for older adults, and for our purposes, we take that to mean folks really over the age of 70. For older adults, little doses, little bits of these medications go a very long way. And so you don't need 5 milligrams of Haldol. You really can see some good effect with 0.5 or 1. Because we're not treating schizophrenia. We're not treating delusional disorder or psychosis. We're treating something different. So you don't need quite as much as you would if you were treating a floridly psychotic patient. And then on the right-hand side, there are some common age-related side effects that are really worth noting and worth paying attention to when you're following up or monitoring for effect. None of these should be surprising. Extrapyramidal symptoms like motor symptoms, sedation, orthostatic hypotension, QT prolongation, very, very common. Quetiapine and olanzapine actually are the more anticholinergic of these medications. You may also be thinking, but I thought we didn't want to give people those anticholinergic medications. And you are exactly right, because those two will actually carry a higher risk of sedation because they are more anticholinergic. They also carry greater risk of orthostasis and urinary retention because of their anticholinergic properties. Risperidone is going to be the least anticholinergic of these four. So if you've got someone, say, who's got chronic orthostasis, chronic orthostatic hypotension from nerve damage, or longstanding diabetes, autonomic neuropathy, I would shy away from quetiapine and olanzapine and instead pick something like risperidone or Haldol, for example. Remember, haloperidol, risperidone, and olanzapine cannot be given to patients with Parkinson's disease because they are more antidopaminergic. Quetiapine is the only safe and recommended option for any psychosis and behavioral symptoms in Parkinson's disease. Next slide. Some general tips for use. Start with low doses, but go up if you need to. So if 0.5 of Haldol or 0.25 of risperidone is not giving you the result that you want, increase the doses until you see the result that you want. And you can do this actually pretty quickly. You can start with one dose, and if you're not seeing an effect after a couple of hours, you can repeat the dose and actually try to explore what is going to be the effective dose for this patient. Consider medications as a bridge. These, again, are not long-term therapy. These are not treating the underlying delirium. The goal here is for stabilization, so that way the team, the interdisciplinary team of providers, can come up with a better, more non-medication strategy to address the behaviors. It actually may be preferable to schedule medications for particular patients in particular situations. So it is not uncommon for delirious patients to have more behavioral symptoms at the end of the day. Again, fatigue is a very real driver of behavioral symptoms. And it happens that a fair amount of delirious patients will have particular reliable hours of the day, like 2, 3, 4, 5 o'clock in the afternoon, where we really reliably see behavioral symptoms come up. If you're treating a patient like that and you know the pattern, you don't have to wait until they're actively having symptoms and causing distress and causing problems. You can actually schedule a dose of medication, say at noon or 1 o'clock, in order to help smooth down what you know is coming in the afternoon. This is not a set it and forget it kind of therapy. These medications need to be monitored. They need to be followed up every day. And sometimes if you're actively adjusting, you want to check in a couple times a day with caregivers, with family, and with patients to make sure we're not overshooting or experiencing some of those negative side effects. Cardiac risk is real, even at low doses. So I always look back to make sure that we have an EKG with a QT interval, the QT corrected, QTC is what we go for, in the records. I don't always get a new EKG. If I have an EKG from within the last 6 months, that's good enough for me. That's good enough for me to get a sense of where are we? Is this a person that I'm really worried about? QT prolongation, or do they have a chronically long QT to begin with? If you want to, the best time to get an EKG to see the impact of the antipsychotic is going to be within a couple hours of the initial dose. So at least 1 hour after and somewhere between 1 and 3. Next slide. Documentation is key. As providers, we often are in the situation of setting the treatment plan and certainly prescribing medications. but communication with all of the rest of the provider team is really critical to make sure that the medications and the other behavioral interventions are doing what we want them to do. So we like repetition. This is the template down here on the bottom half of the slide that I actually use when I'm treating delirium with medications or with significant behavioral symptoms, to actually communicate clearly to all the future shifts, to other providers. Here's the hierarchy of things. Here's the checklist of things that we recommend doing, when and where to give medications, where might physical restraints fall in that hierarchy of things, what do we know works for this patient, what do we know are reliable triggers for this patient, and leave it in lots of different places. We leave it in our provider notes, we leave it in nursing orders, we leave it in sort of general notes on the chart. For all providers, repetition really is key because every provider seems to look in a different place for information. Next slide. So we've reached the end, at least, of the didactic, the boring part of these couple hours. Here are our takeaway points. Delirium is a medical emergency. Don't sit on it. Look for inattention. And I saw a question come across in the chat. Does a patient need to have all those hallmarks to be diagnosed with delirium? The answer is no, the quick answer. But there are necessary symptoms, necessary presentation features. Those are inattention, disorganized thinking, fluctuating symptoms. So symptoms that come and go or change over the course of the day. Those are musts. But there are a whole panoply of other symptoms that you may see depending on the person and the situation that they're in. But those are sort of added features, common added features. Inattention, disorganized thinking, and fluctuating symptoms. Those are musts for the diagnosis. Use the bedside tests of attention. They're very quick, they're very easy, and they're very illuminating. But don't forget, you can also use your observations just from your chit chat and good morning to the patient and their family. That can often provide a lot of information too. Successful treatment depends on answering the question, why is this happening now? Recovery is a process that unfolds over weeks to months and carries a really high risk of residual cognitive and mental health symptoms that we really should make patients and families aware of. Behaviors are a means of communication. They arise as a result of an unmet need, either physiologic or psychologic, and meeting the need can actually resolve the behavior. Antipsychotics have their place, but they are not a treatment for delirium. So they do have their place for the right person at the right place in the right time. Jessica, I think we have a couple more slides. Okay, there's questions in the chat here that I've got up. Conversation between patients and physical therapy is sensitive. That is true. And of course, discussing something really scary like delirium or why is my loved one not acting like their usual self is always sensitive. But I think have a responsibility, like we all have a responsibility to help make sure that our patients and their loved ones are informed about what's happening. And then also to know that they're not alone, that they have a whole team of people and providers that are here to support them through it. And acknowledge that this can be really emotional, it can be really scary, and there's a lot of unknowns. So addressing those sensitivities kind of upfront and normalizing where we can. I do know too, we have a really large Southeast Asian diaspora particularly on the West Coast of the United States, and we do see Thai, Vietnamese, Cambodian, Laotian patients in our hospital not infrequently. And I know it is very common for family members of those patients to not want providers to deliver some particular information directly to the patient, that they would rather have that information as family deliver what's necessary or what's relevant to their loved one. That is perfectly appropriate. It really is about offering knowledge and insight and advice to patients and families that they're ready to hear, and that is going to help them for the particular stage that they're in.
I'm
I
going to
hope
add to
answered
that.
question.
I
Yeah, go
agree.
ahead.
I agree, Katie. And I think too, I think the role that we can all play, no matter what position we are at the bedside, is reassurance and to give patients and families some coping mechanisms like, oh, oftentimes um, we'll see families try to argue with the confused patient, and that makes things worse usually. And so instead, giving them tools like, just provide reassurance. And if they're talking about the bat in the room, say like, don't worry, it's a friendly bat. Or, I mean, these sound silly, but it really takes the family member out of the position of like fighting with the person and just being a source of reassurance and comfort. And I think when we do give patients, families those tools, they kind of get a little more power and feel empowered that they are part of the solution as well, and that it's just not this scary thing happening to them and their loved one.
Yeah. That was a beautiful segue into the next question. That was like it's like you do this for a living, Jessica. Um, the next question in the chat is, how do you teach caregivers or families to help communicate with delirious patients? This is challenging because for a lot of people, cognitively intact folks, caregivers and staff, we want to argue with the confused person, right? We want to say, no, like it's today, this is the date today. No, you're in the hospital. No, that bat on the wall is not there. But it will, in most cases, make things worse.
Mhm.
So we advise caregivers and families to meet patients where they're at. If they are, I had a patient just this week that is recovering from delirium that believes she is in her home, even though she's still in the hospital. And we just don't argue. She talks about how like her neighbors are down the hall and she misses seeing them and such. And like, yeah, I understand that feeling. So acknowledging the emotion or the sentiment to particular comments can often be a really effective way to meaningfully communicate with someone who is actively delirious. Meeting that person where they're at in whatever reality they are in is a very reasonable approach. There are going to be delirious patients that will ask, like, what is the day today? Where am I? What is this place? And in those situations, it is okay to say, well, you're in the hospital. You're really confused right now. Your brain isn't working the way it normally does. And if they're asking for information, we don't withhold information. We just don't force reality on people that that are really struggling with it in the moment. We also really encourage caregivers and family to focus on the familiar. So, what I mean by that is that family, when they're present, we encourage and empower family members to do things like bring in photos or photo albums or go through photos on a phone or iPad, tablet together and go over like, who is this person? Who is that person? Remember this day we did this together. Just because our brains like memory, our brains like routine. And so bringing up familiar and even comforting memories can actually help in the cognitive recovery from delirium. Familiar items like a pillow or a blanket, the quilt or blanket from a bed from home can also be really comforting and familiar and grounding for a person who is confused and looking for cues in their environment. We ask families too for collateral history. Who is this loved one? What did they like to do? What kind of work did they do? Maybe when they were younger, before they retired. Tell me about the family life. Are there grandkids or great grandkids or, spouses, siblings? Because caregivers then can use that information to say, hey, tell me about your grandkids. I heard, one had a birthday, right, and use that even during like hygiene care, medications, to sort of cognitively engage with the delirious person. So we encourage that too. I can't tell you how many conversations I have about pets, dogs and cats in particular, and share pictures of my own dogs, and because that is a really easy way to engage someone socially.
Katie, do you still, when you're assessing a patient, look at the 3Ds like we used to do? What's going on?
Uh, yes. Yes. Connie, you want to tell everyone what the 3Ds are?
I think a lot of them know depression,
Oh, okay, good.
dementia, delirium.
Yes. Yes, we're always thinking about this sort of overlap, the Venn diagram of depression, dementia, and delirium. All three can exist at the same time, which is incredibly challenging to discriminate and pull out. And so in those very challenging cases, sometimes we just have to acknowledge the limits of what we can recognize. When someone is acutely delirious, we are not going to make formal diagnoses of depression, major depression, or new diagnoses of dementia, because none of us none of us providers are going to be able to tell exactly what is the new normal for this person, what is happening underneath that forest fire of delirium. So, but we acknowledge it and say, I'm concerned that there actually is some underlying dementia here that hasn't been recognized before. It's perfectly fine to say that, so it doesn't get lost for future providers, but really draw a hard line at saying this person's immediate issue is the delirium. Down the road, in a few months, when things, the fire has gone out, we need to make sure that we're doing cognitive assessments for dementia. We need to make sure we're doing mood and anxiety assessments for depression.
And I think, Connie, I'm glad you brought that up, because that really gets to the heart of, you have to know what someone's baseline is to know if they are off from their baseline. And we are, in the hospital, are often, well, sometimes in a situation where someone just comes out of the blue. No one has any collateral history. We do have to kind of keep, like Katie said, that suspicion of, like, is there some dementia at baseline? Is there some depression at baseline? Right now, we're dealing with a medical emergency of delirium. And then when the dust settles on that, we can further tease out the other things. But you're absolutely right.
Trauma, prior life trauma is another, it's not a D, unfortunately, but it also falls into that framework that, as people live longer, there are lots of survivors out there of sexual assault, childhood abuse, natural disasters, military struggle and strife, and all of those can impair cognition. We're learning a lot about the effect of trauma on later cognition, depression, certainly, along with dementia. And so you may be in the position too where you've got a patient where you're just really suspicious, like this person is acting maybe like they have some post-traumatic stress. And so always being sure to use a trauma-informed lens, and presume that, particularly as you're taking care of 70, 80, 90, and 100-year-olds, that they have probably lived through some very fraught episodes and fraught moments in their life. And so never keeping that idea too far away.
Before we go to the case studies, if you could summarize 3 things the physiotherapist and occupational therapist could do when they're working with a patient, because my fear is people think they have delirium, I'm not going to provide rehab. What would you say they are?
I'll give you one.
Yeah, go for it.
I think actually that is a really helpful time for therapy. I often look at my therapy colleagues' notes, especially when they say can only follow one-step directions. They needed hand over to, for activities to be able to do X, Y, Z. That is very helpful information. I'm also going to be tracking that as I'm following the patient to know, are we getting a little bit better? Can they now follow 2-step commands? Are they past the, handover for activity? So I think it is still an appropriate time to be able to work with a patient, because it does provide that helpful information. And I'm going for number 2 in that we're engaging patients. We're, having them do activities. We're mobilizing them. We're bringing their brains back to what we hope would be a normal state with some of these like anchoring things. If I miss brushing my teeth and I'm confused, I'm going to feel much more like, oh, wait, okay, this is familiar to me, you know, just by doing these very simple things. But it is very powerful and very healing for the brain to have those anchors and that scaffolding to work on. And I think therapy disciplines, all clinicians can play a really important role in that way.
I 100% agree. The delirious patient is the patient that needs the most attention from rehab experts, both for your expertise in different ways and different strategies to include activity, to maintain safe mobilization, to and then to specifically call those strategies out for frontline caregivers and even family. The other piece that I lament, because we don't do we could do better at OHSU, is utilizing the recreational therapy part of OT. So moving beyond, certainly ADLs are very important, but moving into more of those sort of rec therapy type activities and letting everybody on the team know, here's things that this patient is really going to be capable of doing and really interested in doing. For example, I had a patient with delirium about a month or so ago, and it was the occupational therapist that visited this person that actually it was this person was also recovering from a stroke, and so had significant impairments on their right side, but was a painter. That's what his retirement hobby was, painting. And so the occupational therapist put a sort of surrogate tool for a paintbrush in his hand, and actually, you know, got some paper and a pad and set it up, and they practiced painting together. And then the nurses, once the occupational therapist sort of figured this out, had this light bulb moment, all the nurses then were able to use that same strategy, but for fine motor training, but also just because it was a loved activity for this man. His family was very grateful. I mean, it was really a beautiful intervention that was incredibly successful.
Are there any other questions in the chat?
Not that I see. So maybe if we could have Mr. Tan turn on his camera and introduce our case studies to us. Does that sound good?
Yeah, sounds great.
Okay, Pastor Tan.
Okay, thank you, Connie. Today we have two case discussion from Payathai Hospital and Smithivet Hospital. First of the case, let me introduce Kun Sai Pinya. She's PT, and Kun Sonsawan, she's OT from Payathai. Okay, please be on stage.
Hi, 1 or 2?
Pardon?
Which hospital, 1 or 2?
Payathai. Maybe, I'm not sure. Kun Sai, can you introduce yourself, please?
Yes, I'm just Warga channel.
Payathai 1.
Payathai 2 hospital.
Payathai 2. Oh, okay.
Okay, this case that I would like to sharing for today is Vietnamese male with Stanford type A aortic dissection with status port repair aortic dissection with ventral operation. After operation, he got like chemothorax and respiratory failure. And then the doctor did tracheotomy after that, and he stayed in the ICU at hospital in Vietnam until July 2023. And next patient was moved to the Bam Rung Rat Hospital, and at there, doctor found that he had candida empyema and did right thoracotomy with decortication and removal of loculated pleural effusion. And during this time, he also got acute kidney injury. And then patient was referred to PIH2 hospital for rehabilitation on September 2023. And then the doctors consult physical therapy for exercise, ambulance, and the chest problem. And his underlying is hypertension, sick sinus syndrome on pacemaker, and on severe left side. For him, for delirium problem, he did not know when is day and night time, so he cannot perform normal routine as usual. And also he stay only in his room all day and night. So he do not have motivation to do any activity that help him to improve his physical function at normal routine. And we management, like we advise his caregiver to adjust the room environment during day and night time. At the day, should turn the light on and open the curtain, and at the night time, must turn the light on and close the curtain. In the meantime, during rehabilitation period, we give the exact date, time, and place to him, and also give an educate to the nurse team to tell exactly the same to him. And furthermore, we also change the pattern that we rehab him from the room to be the gym floor exercise in order to meet other people, see the view outside window, and also motivate him to have a normal routine as usual. And the progression before the he discharge, he know when is the day and night time, and he can sleep at night and get improved for his emotion, behavior, and motivate to get better. Also, he can do more physical functional activity as similar to usual. Like at the beginning, he cannot like walk just 5 meters with the moderate support, but before the discharge, he can walk like 50 meters with just only hand touch. Yes, that's the great word that I would like to share.
Thank you so much for that case. When I read this, I thought, I don't know that we have any additional advice to give. Really quick, I want to introduce you all to a nurse that is on our team. Her name is Elena Enna. She's joined us to give some additional perspective for some of these cases. And Elena is like the geriatrics whisperer. She travels all around the hospital teaching people about how to work with patients with dementia, work with patients with delirium, does a lot of nursing and family education, and just changes things all over the hospital. So I wanted to take a moment to introduce her as one of our guests for the cases. I'll put up, I had copied and pasted some of the info from the email, so I'll put it up on the screen. But certainly as you all were talking about this person, it made me think about what a profound hospital experience he had. Just a serious infection, serious surgeries. I imagine was in the hospital for a very long amount of time. And even those things in and of themselves can be such a hard thing for patients to climb back out of, even if they don't have delirium. But the amazing thing is that the interventions that you did for him, getting him out of his room, decreasing social isolation, increasing his mobility, those were things that he would need and benefit from even if he wasn't delirious, because of all those things he had experienced. So I just want to commend you for like having such a creative and patient-centered approach to helping this man recover.
I share that exact same sentiment. The symptom that can be really challenging is the lack of motivation. That's very, very common in delirium. It's also very common in serious illness survivors with or without delirium, and can be one of the trickiest symptoms or barriers to meaningful recovery. what we know about sort of depressive type symptoms and certainly lack of motivation sort of falls under that umbrella, is that medications for older adults like SSRIs and SNRIs really do not work all that well. That the far better, there was a great meta-analysis from the British Medical Journal just a couple years ago that looked at all of the research out there on non-pharmacologic management of depressive symptoms. And it's basically falling right in your camp and your areas of expertise. It was reminiscence therapy, cognitive therapy, exercise, social engagement. I mean, it was everything that really had a good evidence base behind it. And all of them outdid SSRI therapy. So really the approach to that amotivation is doing exactly what you did. Patients like this can be very tricky because when they're asked, like, do you want to get up and walk today? Do you want to do this? Do you want to do that? Oftentimes they'll say no, but we as caregivers and rehab specialists can't let the conversation stop there. We have to use different language by saying, it's time for, we're not asking, it's time to do this. It's time for therapy. It's time to take a walk. It's time for meals, and we don't eat meals in our room. To sort of overcome that hurdle of the amotivation. And this case, I think, demonstrated that really, really well.
I wondered about your assessment. Like, how much was he sleeping? Did nursing let you know how much he was sleeping? Was he sleeping during the day? Was he sleeping at night? Are you there?
Yes, he like awake at night and sleep at day.
Okay.
Or
And what could they do, Jessica, Katie?
Yeah, I think even that has its own social isolation. You know, if you're awake at night, staff are around less, you're being engaged less, no one's bringing you meals, so you're not eating as much. Sometimes we have to do it with a little bit of like just slight course correction, trying to get it, reverse it. But what we do is really focus on keeping someone awake and engaged during the day. There's absolutely no medicine that's going to reverse it without that other piece. So exactly what you all did, having the lights on, curtains open, having him come out for meals. There is a period of time where someone's, kind of nodding off in their meal tray until they make the transition, but it's still critical that is a component of getting that switched.
Oftentimes we find ourselves in the position of using a very short, hopefully only couple days course of a medication to help promote sleep at nighttime. Just in those early days when we're actively trying to help patients switch from their sleep-wake reversal. My favorite in doing this, although none of them really work very well, is trazodone. I usually start with like 25 milligrams. I'm always giving these patients melatonin as well. Melatonin is not a traditional sleep aid. It doesn't make people feel drowsy. But with all neurologic injuries, concussions, traumatic brain injury, strokes, delirium, whatever, the natural production in the pineal gland of melatonin goes down. So supplementing with melatonin is really just replacing what a healthy brain would produce normally. So that's an important part. And then adding on top of that, say 25 of trazodone at a reasonable bedtime or whatever's normal for that person. Ideally for like 2 to 3 nights, while you're also doing all of the good daytime activity, can really help make that switch stick.
Mm-hmm. Elena, do you want to add anything to that?
Hi, everybody. Thanks for having me. We see this a lot in the hospital with the sleep-wake cycle reversal, and it can go on several days, and we'll try things, and often we'll have to turn to a medication. But before we turn to a medication, we want to make sure we're protecting their nighttime sleep as best as we can, which means here in our hospital, stopping the middle of the night tests and vital signs and medications and antibiotics that can be administered at different times of the day. So we want to make sure we're not bothering them when they're getting their best hours of sleep. And so usually we post a sign on the door that says to try not to do not disturb between these hours. So the staff can still go in and like peek in and check on them to make sure they're safe, make sure they don't have any needs and they're not in need of any assistance, but we don't go in and wake them up for a blood pressure if they've been stable for days and days with their vital signs. I also encourage the nurses to, our physical therapists and our OTs do a great job mobilizing our patients who are delirious, but they also end their shifts at like 3 or 4 or 5 p.m. So I always encourage the nurses to do another fatiguing activity before bedtime, whether that's getting up in the chair for dinner or, you know, getting up after dinner, using the bathroom, and maybe going on a good walk. Just some other activity before bedtime where they're expending energy, and that will eventually help with sleep as well. So those are 2 things we also like to make sure we're doing.
In the rehab world, we use the patient-specific functional scale as our patient-reported outcome. And in this case, I think they could have done it with family to figure out what were the patient's routines at home and things they love to do. Katie, when you said that about the painting, one of our dementia, Center of Excellence for Dementia is that art, that cognitive and brain work through art, right? So did you ask the family what the patient liked to do prior to the stroke? That would be something you could use the patient-specific functional scale to really promote what the patient wanted to do and bring back some alertness to them.
To that end, there is a great question in the chat about the effect of music therapy in delirium. Wonderful question. Art, one of the beauties of artistic endeavors and music is that they activate multiple sites across the entire brain. So more so than even just walking or doing sort of tasks, you know, even familiar tasks with the hand, any opportunity to bring in sort of art in any form, art, music, creation, or just appreciation, activates a much wider swath of the brain and different synapses and pathways. So from the evidence, the published evidence, I'm not aware of much out there on music therapy and delirium. There's more on music in dementia. But that said, anecdotally, this is a tool that we keep in our toolbox as well. I had a wonderful patient that I will never, ever, ever forget years ago who had a terrible episode of delirium that lasted for weeks. And she was very aggressive and exit seeking and was just, it was really very stressful for her family, and for the staff. And the first intervention that we found really worked with her to help her feel calm and even helped her like talk a bit more calmly with the staff was music. And it turned out, we learned from her family that she was a bartender in like a country western bar. And so we found a country, like old, like women of country Pandora station on the TV in her room that she listened to all day long, every day. She was particularly fond of Patsy Cline, and would even sing along when favorite songs came on. And the one-on-one attendants that we had with her for a good long while, they would sing with her. It was really, really a great tool. Any song or music helpful for sleeping better? Ooh, that's a good question. I come back to, I'm sure Jessica and Elena have thoughts on this too. I come back to what is loved by the person. I know it seems weird, but there may be people for whom like the blues or even, classic rock may be soothing and comforting for them, whereas like classical music or sort of traditionally more relaxing music may not be. So yeah, I think this is really person dependent. What do you guys think?
I agree. I totally agree. Whatever music is relaxing to some people might be totally stressful to me, but I think patient preference.
Mm-hmm.
What about the person that usually falls asleep with the TV on? Would you recommend that with a delirious patient?
In my opinion, that's not totally ideal because I think when you're getting that like flashes of light, I don't know how restorative it is, but there's a period of time where we'll do whatever seems to work, and if you are asleep at night with TV and that's your pattern, we're going to have to go with it until we can regulate your sleep-wake cycle. And maybe someday we'll be able to move away from it, but TV-induced sleep is better than no sleep, is my thought on it.
Agreed.
Okay, are we ready for case number 2?
Okay, Connie, you get chairs already, and then you can share on the this show. Do you hear me? It's like an echo. Okay, case number 2 is from Smithiwedศรีนครินทร์ Hospital. Kunat PT, you can show on the stage.
Sawadika,
Thank you.
Kunat.
Thank you very much.
Hello everyone. Do you hear me? My name is Nat Sinsupon. I am a physiotherapist. I work in the inpatient department. I am from Smith-West Sinakurin. Today I have case presentation, diagnostation, Delirium with dementia. He is the Thai male. He had history of falling, his back crushed down on the floor, and bursitis occurring on his right rib with low blood pressure. He was referred by PM&R from PT program to relief pain, exercise, orange, and ablation. At the beginning, he wasn't alert much because of the medication and refused to do exercise. The team decided to discuss with him and parents again about his meaningful goal, which is going back home. After that, he has more motivation and more cooperate with exercise. This case is stay in hospital for short term for 3 days. We have not much more done about him. But after he discharging, he get better and more good cooperation.
Can I
I
ask
love-
can
go
I ask
ahead.
a clarifying question? The medications, you mentioned issues with alertness and maybe staying awake because of medication. What medications were felt to be problematic?
May need the chart.
Oh, fair. Totally fair. I
I'm
ask,
not,
I'll start there, is
not sure
that
about the medication because I meet him about the last visit to discharging from the hospital.
fair.
He has so short term to stay.
Well, the reason I ask is that this is a really common scenario that we see in acutely injured older adults, a lot of them with dementia, is the balance between untreated or undertreated pain from their injuries and the effects or unintended side effects of pain medication. This is a huge area of potential conflict between providers in the U.S. There is a lot of fear amongst providers in the U.S. about opioids for older adults and for people with dementia and other cognitive impairment. But that fear is really overblown. Honestly, what we know is that undertreated pain from fractures, from other injuries, is actually a more potent, more sort of bigger delirium driver, and a bigger risk factor for behavioral symptoms, for worsening function, for faster decline of cognitive impairment than any risk of reasonably prescribed opioids. So for this patient, I wonder if the issue may have been a pain regimen that wasn't adequately treating the pain from his injuries, and rib injuries hurt like crazy for about a month or so, month and a half. That's a long time for someone with dementia to be uncomfortable.
Accidentally stopped my screen rather than unmuted myself. Wrong button. I agree. And I think our team is often in the situation of trying to advocate for appropriate pain control. Because what we also see is, especially with patients with dementia, when they aren't able to advocate very well for themselves, is they'll end up in a pain crisis. Then they get gobs of pain medicine, and then they're sedated. And then everybody thinks, oh, we can't give them any pain medicine. Then they end up in a pain crisis. They get a ton of pain meds, they're sedated, and we repeat this cycle. And so, in the talk, we talked about even just very low doses, a few times a day, can help bring that level of pain down so that people aren't kind of doing this up and down cycle all the time and just get a little bit of consistency. The other thing I thought was great in your case is you were able to work with the patient to identify a good motivator.
Yeah.
Because, well, especially when you have to work through pain and when you have some cognitive impairment, you and I can say, Jessica, this is going to hurt, but if it gets you home, you'll just work through it. But when people have short-term memory impairment, they can't self-soothe like that, or they can't, necessarily multi-stage plan like you and I can. And so having that motivation as that carrot front and center, I want to get home. We're going to do this so you can get home. And then bringing that level of pain down, I think, is an important combination to help move people along and get them interested.
I think as rehab specialists in particular, you all are in the ideal position to know and give feedback to other members of the care team as to whether or not medications are helping or hurting, and whether or not we need to do more or something different to manage acute pain, even chronic pain. You all are in the best situation to see how do those symptoms change with varying levels of activity, and to use all of your expertise and assessments to help inform the correct prescribing, and the best prescribing for each patient.
Sorry, I missed that, but I was thinking, how can we make the OTs and PTs more advocates for patients and pain?
Mm-hmm. There is a tool that I know came out of the nursing world. Elena's smiling at me, so I know she knows what I'm going to say. There's an assessment tool that is specific for pain in dementia patients, cognitively impaired patients. Remember, a lot of these tools and tips and tricks are actually interchangeable for dementia patients, delirium patients, other cognitively impaired patients. There's a lot of overlap in the approaches and the tools, the assessments. But this one in particular, I really like because it really speaks to the different way that pain manifests in people that are cognitively impaired. It's called the Pain-AD scale. AD stands for Alzheimer's dementia. That's the population in which it was first validated, but we use it for all sorts of cognitively impaired patients. And it's really easy. It's a scale that grades certain behaviors and certain reactions, like to movement or to touch, or to social activity. And the higher score, oh, awesome, thank you. The higher the score, the more likelihood of, or the more significant discomfort and more significant pain. And so this touches on really nothing verbally reported by the patient. It's all things that we can observe as caregivers. And there's no reason to me, even though this came out of the nursing world, there's really no reason that it has to be limited to nurses. I think this could be a really powerful tool for rehab staff. I know I use this framework when I evaluate patients that are cognitively impaired, and I'm trying to determine how much pain might be an issue.
Found one with a calculator.
So, and this is open source. I usually Google it when I need to find it. So it's open source and available.
What more can you add, Elena? Sorry, we should be asking you more questions.
No, well, before we had the pain AD scale, we used the nonverbal pain scale for patients with cognitive, either dementia or delirium. So just using the furrowed brow and their body language as our a tool to assess pain. And but now that we have the pain AD assessment in our computerized charting system, we're spreading that around as well, because we do like that one a bit better for patients with dementia.
Another thing that I think we can leverage Elena's expertise. She had texted me while we were talking and asked if we were going to reference the cognitive pyramid.
Yeah, I was just going to ask you, how come nobody's talked about the cognitive pyramid?
So I'll look for it and I'll pull it up, Elena. If you wouldn't, oh, Elena already has it, of course.
Yes.
Elena, you want to walk everybody through the cognitive pyramid?
So I texted Jessica when the person that asked about how do we encourage staff, families, caregivers, how to best communicate with patients who have delirium. One of our wonderful OTs and one of our nurses developed this. I think it was one of their masters in nursing education projects they were working on in their training. But it came about because we didn't recognize a change in cognition quickly enough to address the patient's environment and make sure it was safe. So a patient had a decline in cognition in their delirium fluctuation, and they fell. And so it got the OT and the nurse thinking about, what did we miss here? What could we have caught beforehand and changed in the way we adapted their environment, or were speaking to them to meet them at the level they were at cognitively. And this pyramid is what came out of that work. Everyone here on the call it's late in the day for us here, so maybe we're not quite at the top, but most of us are at the top here at executive function. And so on the right-hand side, it talks about the best ways to interact and communicate with people who are at this top level of the pyramid. But when you have a patient who is delirious and who's maybe pretty hypoactive in their delirium and not engaging, not holding their attention, not able to do multi-step commands. This is what we use for nurses most of the time, but also we give this to families who want to know, what can I do to make sure I'm meeting them where they're at and I'm communicating at a level that they can understand. It's a busy screen, so we can send this out to you guys, but basically the left-hand side talks about what the behaviors we're seeing in the patient, whether it's their orientation and their ability to recall and follow commands. And in the column on the right is how we adjust our care to meet them where they're at. So a lot of it is understanding their awareness of their environment and making sure we're not talking at the opposite side of the room with 6 other people in the room joining us, and the television's on and it's just too chaotic and there's too much going on and there's just clutter all over the place, and the patient is just not able to understand anything because it's just too busy, too chaotic. So this really dials it down to making sure we're providing simple commands when needed. We use this, we've also translated a lot of these interventions into our documentation. With shortcuts, we can just type in like attention, for example, and that will pull in all of these interventions for the staff into the documentation or into the note that we're writing. But I do use this a lot for families who have a hard time understanding why their loved one is having such a hard time and how they can best help them.
So the authors of the Cognitive Pyramid taught 2 of the Thai cohorts that came to OHSU. So the Cognitive Pyramid should be across BDMS hospitals, but I just sent the article that was written by Mariah Hayes and Sabina Kulkarni. So we've been trying to get Sabina to go to Thailand for years. So maybe one day I can get her out of Leavenworth, my favorite people. But I'm glad you brought it up because I think we don't think about it when it comes to the delirious patient. And I think we should. And I think we have some lovely activity carts. Can you talk to them, Elena, on our floors?
Yeah, actually, another OT on our neuro unit worked with one of our neuroscience nurses, and they took the cognitive pyramid and they figured out occupational therapy activities that they could help stimulate the patient and engage the patient based on each level. So I wish I had the ability to show this to you all, but on our neuro unit, they did make a binder of activities. And I'm thinking, it's some of it is like blocks or coloring activities or puzzles, sorting, things like that. And so it just depended on the level of cognition in the pyramid, and then it would point you to an activity that met that patient at that level for their occupational therapy visit. So we do have supplies like that scattered around the hospital for those patients.
Are there any other questions that anyone has? I'm notorious for filling up space if there aren't any. I will say, since there aren't any right that second, and I didn't give you much time, the geriatrics team works very closely with our rehab colleagues, and we really rely on one another's assessments to be able to do what's best for the patient. And I wanted to make a point of that because I think my hope is that people leave here today knowing the importance of the interdisciplinary team, to address and treat and prevent and even identify delirium, especially with the waxing and waning. Someone's going to catch it at a different point that, you know, someone else won't. And we really it really is a multidisciplinary approach to identifying it and management. So I hope that you all feel empowered about the important part that you play in managing this.
And I want to tell everyone that Dr. Katie Drago and Jessica Wright are on our developing our COE dementia and brain health team. So these are two experts that are going to be developing this incredible program, and you'll have an intensive week with them if you're a candidate and are going to come to OHSU. So I'm really excited about that. Katie, your age-friendly health system really fits into this talk too, when you think about the 4 R's, is that right? The 4 M's?
4 M's.
See, I'm not good at it yet, Katie.
Yes, the 4 M's is a perfect framework for approaching complex diagnoses like delirium, but also I think plays a role in cancer care, trauma care, complex illness management. It's just an incredibly helpful framework to sort of geriatricize the care that you're providing for older adults. For those who aren't familiar, in our last few minutes, I know we have another session. I think you get me again in a few weeks over lunch to talk about age friendly, but this is an initiative, quality initiative from the Institute for Healthcare Improvement here in Boston in the States, that they put this together with geriatrics experts of all disciplines from around the country to really distill down what are those core best practices in care for older adults across settings that providers and teams of all disciplines can use to deliver the best care for older adults. And the framework is the 4 M's. The first is what matters, sort of an M, which speaks to the right care at the right time for the right patient. So eliciting who they are, what's important, what goals do they have for themselves, for their health, for their future and remaining life, so that we can then tailor care to match those goals. This umbrella includes end-of-life care and care for the dying patient, but is not exclusive to end-of-life care. This principle is applicable to really anyone at any stage of life, but really any older adult at any stage of health. Medications is the second M, and this speaks to avoidance of high-risk medications that can impair function or that don't work towards what matters to the patient. There's a lot, I could talk for hours about medications, I won't bore you, but there's lots of tools to help avoid some of those medications. The Beers list put out by the American Geriatric Society is one of them, but there's a ton of other really good, useful tools for deprescribing and meds to avoid in older adults. Mobility is the third M. I feel like I don't have to belabor this in this crowd, but mobility is all about function and preserving, maintaining, and restoring function and independence as much as is possible. And then the last M is mentation, and this is Connie's 3 Ds. This speaks to depression, dementia, and delirium, prevention, recognition, diagnosis, treatment, and planning for all 3 of those domains under the medication umbrella. All of these apply across the settings of care. And so the ideal state for the entire healthcare system is that any older adult receives really high quality 4 M's care in the hospital, in the ICU, when they're in rehab, when they're home and they're going to their primary care or regular clinic doctors and clinic providers, that along every step of the way, we as care teams are attending to each of those 4 M's. That's the goal. You'll hear more about it in a few weeks, but I would love, there's a certification from the IHI that they offer that is free. There's no enrollment. It's not, or no sort of formal vetting process like some of the other site certifications and such. This is a certification that the IHI will offer based on proving that you have systems of care that exist to deliver all 4 M's. And I would love, I know as part of the COE for brain health, we would love to help any interested BDMS hospital or the entire system achieve age-friendly health system certification with the IHI. You all would be the first in Thailand to do that. And so I'm sure the IHI would love to have your commitment and partnership. Oh, good. Jessica put in the chat a link to more information directly from the IHI about age-friendly health systems. There's lots of great information on this website. Read, learn, send questions through Connie. We're happy to answer anything. And again, we'll talk more about age-friendly in a few weeks.
Wow. Okay, we didn't think we could fill 2 hours.
A lot of faith in us you have, Connie.
Comprehensive, very, very comprehensive. Thank you very, very much.
Kukinka, Dr. Wanapa.
And we already have Connie interview some candidates for dementia and brain health and tell them about super comprehensive content that we have to go through. We
Yes.
lots of things to be working hard. Thank you very much.